Major funding for these programs is made possible by grants from Chase Commercial Term Lending and Capital One Bank, New York Community Bank, the Witkoff Group, M&T Bank, Perfect Building Maintenance, Genova Burns, Jean Tomasi and Webster, Greenberg Traurig, Kilroy Architectural Windows, New York's Window Company. Additional funding is provided by grants from AKA Hotels, Corman Communities, Aerial Property Advisors, Bank of America Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Colliers International NYC, CPEX Real Estate Services, Cushman & Wakefield, Customers Bank, DDG, Dime Savings Bank of Williamsburg, Douglaston Development, Levine Builders, First Nationwide Title Agency, Flushing Bank, Friedman, Gemini Real Estate Advisors, Hap Investment Developers, Herrick Feinstein, Investors Bank, James D. Kuhn Real Estate Institute at Syracuse University, James Orphanides, Chairman USRealty.com, John Katsimides, Red Apple Group, Margolin Weiner and Evans, Madison Realty Capital, Massey Knackle Realty Services, Matone Group, Meridian Capital Group, Newmark Grubb Knight Frank, New Banks, People's United Bank, SJP Properties, Sterling & Sterling, Stonehenge Partners, TD Bank, Terra CRG, the CUNY TV Foundation, the Continuum Company, Urban American, and these friends.
Healthcare in 2014. It's a different world. I mean, there are CityMD urgent care centers, there are doctors running practices, there are these large groups, there's everything over there. Who understands what's happening over there? I really don't understand. So I've brought together 4 individuals who are going to provide their insight on what's really happening in the trends in healthcare. My guests today include Arthur Klein, who's the president of the Mount Sinai Health System, Dr. Shami, who's the COO of CityMD Urgent Care Centers, Bob Glazer, who's the CEO of ENT and Allergy and Associates, and last but not least, Anthony Ferreri, who is the president and CEO of Staten Island University Hospital and the regional executive for North Shor-LIJ system. So you're the kid over here, okay? These are the older guys over here. You know, we remember, you know, when I remember, you know, an urgent care center, there was a Medicaid mill in some of the neighborhoods that you and I remember, which, you know, that you couldn't get a regular practitioner to go to. And I also remember when doctors would go to people to make house calls. I mean, we're going into that. So how many locations do you have? What are you doing today?
We've come
Who
a
are you
long way.
competing with?
We've come a long way from that point, fortunately, for the patient. You know, the first thing that's changed is, I think in general in healthcare, we're listening to our patients more. So in terms of a trend, I think patients are going to tell us what they need, and hopefully the healthcare environment will respond to the patient as a consumer, which is really a shift. The patient has a choice in where they can get their care, and what we're trying to do is listen to what they want and then deliver that. And I think what they're looking for is access and quality and cost. And as an access provider, I think we can.
Couldn't you get good quality care at the North Shore-LIJ system or the Mount Sinai system, otherwise known as the 800-pound gorilla that has all of these hospitals over here? Okay.
I think there's a perspective here, and that is, and I'm old enough to remember healthcare, as you say, when it was different. In those days, many families, many people had identifiable doctors. The family doctor, the person they went to, who would either come to the home, as you said, or advise them over the phone. One of the very important niches that urgent care serves is it serves a population that doesn't have access to the family doctor anymore, doesn't have access to a primary care doctor. and gets its health care needs met by people who are very qualified, very committed to do the right thing at that point in time, and quite frankly, from the healthcare system's point of view, very often refer these people into a system where they can get continuity of care.
I mean, what in Staten Island, let's talk about what many people, when they have an emergency or a perceived emergency, they go to the emergency room. Now they have this alternative, okay, of what you need to be treated for at the urgent care center. What do you see?
Well, if you take the example of Staten Island, you have a situation where there are just 3 hospitals for 500,000 people. At Staten Island University Hospital, with 2 campuses, at one campus we see 95,000 emergency room visits a year. At the other we see 35,000 emergency room visits a year, as Arthur knows. And in that kind of a situation, we don't always get people that really need an emergency room. We get people who don't have access, as you've indicated. They don't have access to a doctor's office in the middle of the night or after 5 p.m. They don't have access on a weekend, perhaps on a Sunday, more likely on a Sunday, no access. So the alternative is to be seen in the emergency room. And then there are a lot of people who get turned away by a private physician's office who don't have the ability to pay for the care that they get, or may be covered by Medicaid in a private practice situation where the physician doesn't accept Medicaid payments. So you have other alternatives that are available for access to care. And the urgent centers serve another purpose.
But,
in that regard.
let's say I have a sinus infection. I'll give you a great example. My wife, she has this inordinate, and this recently happened. She has a sinus infection. I happened to send it to Bob, and then she felt that the doctor said it's not a sinus infection, and she was screaming at me and literally saying, I want to go to the urgent care. I was going to call Ned, okay? Because she's not sure of what her condition is. But the good thing about Bob, because of the size of the group and of their quality, she was seen the next day. Or that day, even that day, which is, at one time, when could you see a specialist the same day?
So we are certainly a little bit different in that we are a single specialty surgical group, but ENT is very much of a primary care subspecialty. And certainly access. That's always the name of the game. One of the things we like to say is call us today, see us tomorrow. Access. People don't want to wait. They when you call a physician's office and you're told, well, we can get you an appointment a week from now, that's unacceptable. Not in this day and age. So we strive to get our patients appointments same day or the next day. I will tell you, we're in this market right now, and I do think that we're starting to feel some of the effects, the negative effects of not enough primary cares, and electronic medical records are certainly slowing down the systems. You need to expand office hours. We are looking at expanding office hours till 9 o'clock at night and into the weekends because, again, people, you get sick on a Friday night, you don't really want to go to an ER. It's not the appropriate spot. What are your alternatives? CityMD is a great alternative, right? ENT and Allergy is looking to expand its night and weekends hours to meet that need.
Let's look at another trend. I mean, 5 years ago, 10 years ago, if we said ambulatory surgery, I mean, today, most of the surgery, most of it's ambulatory. I mean,
That's correct.
Okay, why do we have ambulatory surgery? Why are we having these freestanding ambulatory centers? And why do we have what we would call these Article 28 facilities, who are doing a lot of gastro procedures, colonoscopies and other things? And, why has this happened over the last couple of years?
Well, I think all of us who are recognizing that we face significant constraints in the resources we as a society can dedicate to healthcare understand that we have to continue to evolve and model what's more efficient and at the same time comes out with a better outcome. Surgery centers have created models of efficiency, focus factories that a surgical pavilion in a hospital can't create by virtue of the complexity and the variety of cases it deals with. So when I talk to doctors and they tell me why they want to be in a surgery center, the investment opportunities aside, they tell me it's the most efficient way for them to practice. to deal with
But
patients who
don't
come in and out.
you, in the Sinai hospitals and in the North Shore hospitals, don't you also have day surgery besides freestanding day surgery facilities?
Yeah, we do, and Arthur will tell you that the Mount Sinai system does as well. And to be frank, we have seen a drop in the volume that we do in our ambulatory surgery centers on our own campuses. So there's a bit more competition here, and I think that the environment in healthcare has changed to the point that there's much more competition than there had been in the past, and a lot of the competition is with the hospitals. And so I think what you're seeing a lot more of is the hospitals and the doctors deciding that we can do these things together and not compete with
Now, but isn't that something that Sinai did do on the west side and the east side?
We did, but we did it in a way that we felt was sensitive to the needs of the patient and efficient. So there's a level of acuity we feel that can be done safely in an ambulatory surgery center. There's a different level of acuity, even if it's ambulatory, that's most safely done in a hospital, where you have access to much more quality control and many more specialists. And when we open an ambulatory surgery center, we're sure that we have the quality control, the laboratory control, the anesthesia control, and the committed credentialed providers who ensure us that our brand on that center makes sense.
So my question is, are you owning the surgery center, or is it a joint venture with the doctors? You know, what's happening?
It's partnerships.
And
exactly the same.
I would tell you that for ENT, probably about 90% of our cases are ambulatory. For our physicians, many have equity interests in joint ventures with hospitals in ambulatory surgery centers. On the other hand, there are certain cases that our doctors won't do it in an amp surge. They want to do it in a hospital-based facility because it's more tertiary in nature. Maybe it's a thyroid case. They want to make sure they have the right backup team. I think you got to, you know, when you're taking a patient into surgery, you've got to, as a physician, decide which is the safest place to do that and what kind of surgery are we doing here. If it's tubes and tonsils, you know, amp surge is fine. If it's a thyroid, you're probably better off doing it in a hospital.
And Bob brings up an important point. If it's tubes and tonsils, it's fine within a certain age group.
Right.
But having run a children's hospital, I can tell you that one of the things I was most proud of is saying that below a certain age, a child shouldn't have tubes or tonsils done in an ambulatory center because the possibility of a respiratory problem or an underlying problem was such that even if it took longer, it should be done in a hospital.
But now you bring up another interesting thing. St. Vincent's closes. So the North Shore-LIJ system is building basically an emergency room and a surgery center, right?
Yeah, as opposed to an urgent care center, this is an Article 28 freestanding emergency room, the same type of facility that you would find inside of a hospital. It's something new for New York City. This is the first of its kind in New York City, but it's something that makes a great deal of sense for a community that still needs to have an emergency room, but might not necessarily need additional beds.
But isn't that the situation that's presently being discussed in Brooklyn also?
At
on
Long Island
on
College
Long Island
Hospital.
College Hospital?
That's correct.
That's correct.
Where that situation, because they need something there. I mean, Brooklyn is underserved, hospital-wise, correct?
Well, Brooklyn is, from a standpoint of inpatient beds, Brooklyn is not underserved. Brooklyn has a sufficient number of inpatient beds to serve the entire borough.
It's the question of where they are.
That's a very good point.
That's part of it, and it's the question of a healthcare system in evolution and what's the best access and what's the best treatment for a patient.
But here's, you know, Bob was talking to me earlier about what happened due to the cold weather in January and February. So there have been two things that have taken place over the last year. One is Obamacare, or the changes in health insurance and deductibilities of how much somebody is paying, and the fact that the cold weather, and it's had an effect on the revenues of all of you.
Correct.
Okay? Are patients reducing the amount of time to visit the doctor? Do you see that because they want to save money because the deductible and the copay is greater?
There's no question in my mind that's happening, and coincidentally, Bob and I, who were together earlier today in another meeting, discussed this. Clearly, first of all, I think a lot of patients, and you see this at CityMD also, think they're covered but don't quite understand the complexity or the range of what their coverage is. And they're sometimes very startled to understand that they may be restricted in the doctor they go to, or if they're not restricted, they may have a degree of copay or deductible that's quite surprising to them. And for many middle-class families, even a significant financial reach.
Well, aren't there certain, I mean, I don't believe it's in your system, in the hospitals of either system. I mean, isn't the fact that Memorial and I think maybe Hospital for Special Surgery does not take everybody's insurance?
I think that's probably true. But it's not just, and I think with the exchanges, I think there are hospitals all over the region who aren't in every single product anymore.
Right. The interesting thing when Ned was...
That's going to continue.
Recently, I did a show on healthcare explaining it because nobody understands the layman, and I had one of their medical directors who's involved with Oscar, and Oscar, being an exchange, has an unusual thing. They have the relationship with Memorial, but the irony is that most of the people who are joined Oscar are really younger people. So there's a diverse change of what of the procedures versus what they really need.
I think, you know, the business climate, businesses across the country are looking at what they're paying for healthcare, and we've seen, you know, the inflationary nature of healthcare expenses explode over the last 10 years, and the result is business is reacting by saying we're pulling back on some benefits to employees. They're shifting the cost to employees, and employees have a new reality that what used to be a $10 or a $20 copay is now a $50 or $75 copay. And a $50 or $75 copay in today's world, people think twice.
I think the best example is somebody who really figures out the emergency room. They say, we're going to go into the emergency room, it's a $500 copay. Right. While I can go to CityMD and it'll cost me $80.
Yeah, I think we have to, the patient needs options at the end of the day in terms of entering the system and access to care. Whether it's diagnostic options, I don't know what's wrong with me, right? And they need a point, they need to enter the system and understand that, okay, this is an ENT issue, or this is actually a headache and you need to see a neurologist or a primary care doctor. That level of access being provided is critical, and it'll also contain costs at that point because you won't have overutilization. And the patient responsibility is going to grow, so utilization is going to go down.
Arthur?
But let's not forget a very critical point. If you are a private corporation or a professional corporation rendering health care, and by the way, I have great respect for CityMD and the urgent care model, you can make decisions about what insurance you accept or don't accept. We can't do that as a hospital system. We are obliged, and believe it's part of our mission, to take everyone who comes through the door. And that has an adverse selection for us on an economic basis. It's a reality we live with.
And it's also based on geographics, okay?
And it's based on geographics.
It's a geographical situation on that.
But when you talk about access, you do need to remember that hospital systems in New York, which are entirely not-for-profit, accept all patients, do it willingly, and are mandated to do that. And that's not true of different healthcare providers.
You know, you bring up an interesting situation. Advertising, which Bob does, all of you do at a different level. But one of the large ads that I see all the time when I'm watching television, which is not that much, is that I see the Cancer Center of America, this, which is a for-profit operation, advertising all the time and trying to go to the consumer and saying, while we have the best cancer centers around in New York, in our region, you know, they're trying to get them to go to Philadelphia or other places. Now, I also see Cleveland Clinic spending an inordinate amount of money, and I know the North Shore has a relationship with that. I mean, advertising has had an effect on healthcare also.
Oh, no question. And no question that there is brand recognition in healthcare as there is in every other consumer-oriented product.
Now, one of your major roles today is to recruit doctors?
That's correct.
So how do you recruit doctors away from him? Or no, how do you recruit doctors in today's world? Why should they go to you? I mean, I know it's Mount Sinai, but, you know, I like Dowling and the boys over there, you know, or I can go to Safer over there in Montefiore. Why should we go to the Mount Sinai system? How do you attract doctors today?
Well, first of all, you have to understand what a particular physician's looking for. Are they going to move their career in an academic way, and do they want to be more involved in that? And that might give you an advantage or a leg up in recruitment. Are they more interested in a particular geography? Are they interested in a group practice versus being embedded in a smaller practice? So like any other arena where you are trying to attract talent, you start off with the proposition, I need to understand what, and in this case I view the doctor as my client, I need to understand what my client is looking for and see whether I have a sweet spot.
Are we doing a Mariano Rivera? Are we giving them bonus? Are we signing up bonus points?
Well, I will
okay,
say-
in
I will
certain
s-
cases, I do know that
Well,
these guys got a bonus maybe from you guys, you know.
Well, I
They
will
signed
say-
up somebody a couple of months ago, big urologist, Dr. Cut, you know.
And then we signed up a urologist from Cornell.
Okay, so, you know.
I will say this, and I think all of us who are reasoned executives in the field, on the one hand, want to attract the best talent we can. On the other hand, we know that we're in an environment where there's excellent health care in multiple systems, and we're all concerned that some of the competitiveness in recruitment is driving up the cost of health care. We are all concerned about that.
And if I can comment, and it's a very complicated situation, but when Arthur mentioned the situation that we have, that we are both not-for-profit systems, and we happen to be in a state, New York, where we don't have any for-profit entities running hospitals. And we do, because it is our mission, and because we gladly accept it. We accept everyone through our doors regardless of their ability to pay. But in order for us to provide the free care to the people who can't afford to pay for their care, and in the case of just Staten Island University Hospital alone, 28% of our business is Medicaid business, and another $28 million is spent on charity care. In order for us to pay for that charity care, we also have to have providers that actually insurance third-party payers, self-pays, people who have the ability to pay for their care to offset the losses that we have. Now, when we're in competition with a private for-profit entity that basically takes the paying customers out of the hospital, now we have more of an issue that we have to deal with. So we have to be competitive. And that's why we've seen situations where we do have partnerships with private practices, because if those
And
patients...
strategic alliances also. I
Absolutely.
mean, you have strategic alliance with with all these institutions. I mean,
I like
Sinai-
this for ENT, and I think this is a world where everybody's dating and there's some kissing going on. At ENT
Seduction is
analogy,
early.
you know, I like to say we're everybody's best friend, and part of that is the reality that we have 40 offices from Poughkeepsie to Southampton to Central Jersey, and it crosses a lot of different health systems, all of which we have colleagues that we respect in, and the services at all those different institutions are ones that our patients need and that our physicians respect.
You know, Tony brought up the subject of Medicaid and free coverage.
Yeah.
Tell me about this new crazy idea that you guys are doing.
I don't know if it's crazy, but
Okay.
we're excited about it. You know, I agree with everything you're saying. You know, as a private company, we can pick and choose. Although part of our kind of core DNA, basic philosophy is to be an access care provider. That's the end of the sentence. In order to do that, you have to care for everybody, all payers. So we're very excited to announce a project that's going to be launched in Jackson Heights, Queens, this September, we hope, that will really focus on providing that quality access care to the managed Medicaid and straight Medicaid payers in order to deliver on the promise of building the first floor out completely. So, you know, we claim to be an access care provider, and we intend to do that. So we're going to launch this project. It's called HEAL. It's a CityMD company, and it's going to care for everybody, independent of their ability to pay.
That's great.
Very good.
So what other trends are we seeing? Okay, are we seeing more doctors want to be working for a hospital or affiliated with a hospital?
So
today?
that's part of it, but I would say that there is number one, we see doctors who are a different generation. Work-life balance is important to them. Right. We see many women entering the field who have multiple responsibilities. We understand that there's an appeal to specialization. At the same time, we have an increasing need for primary care. And we understand that culturally, we're dealing with far more diverse workforces and populations than we had to deal with as young executives 20 or 30 years ago. So this environment is very, very complex. We do understand that healthcare, if we're going to be able to afford what we need to afford for America, is going to migrate out of the hospital as much as possible, be local as much as possible, and be efficient as much as possible. And we're all tremendously concerned with cost and quality and how we can continue to maintain quality with cost.
So here's a question. All the cost, all the quality, and all this, if we have ambulatory surgery centers, if we have new facilities, CityMD, we need capital, okay? Nonprofits have difficulties, you know, your ratings and other bond ratings and so on. How are you doing your expansion? How are you growing your businesses?
Well, you're seeing a lot of hospitals come together. There are certain efficiencies in size. There are certain efficiencies in joining together back offices of the hospitals.
Even though I called him the 800-pound gorilla, I think you got 16, so you're not too far away. Okay, and you got some nursing homes and some other centers, so you know the clash of the titans might not be too far away.
And it's all a sign of the times. It's all a sign of the times. Hospitals, if you go back 18 years ago, when Staten Island University Hospital joined the North Shore Health System at the time, people were very leery about losing autonomy. The board didn't want to do this, and they thought it over, and they never thought that they actually would lose autonomy. But the real world today is that for hospitals to compete and to survive, they have to be part of a larger system. Still have a say in what happens with their destiny, but be part of a larger system.
Well, one of the reasons on the other side of the equation, that doctors are joining groups, and doctors are no longer going to solo
look,
practices, access to capital and
I
resources.
was saying to Bob before, he has 140 doctors, okay? You know, there are very few large groups. I mean, WestMed, which is, has an affiliation with you, and you know, there are more in Long Island who are over there, but there aren't that many large groups. I mean, it's very hard, especially, we don't want to demean, you know, the two of you being physicians. Physicians and business never really played together, you know.
I would take exception to what you said. I think when you do a deep dive, there are in fact many more large groups than
Really?
you're aware of. There is a preponderance of large groups now driving healthcare delivery in this area.
And how many? What about hospital-based large groups?
Well, the hospital-based large groups have largely been faculty organizations. And while they've been wonderful with respect to quality, some of the evolution we're seeing is that they had multiple tasks. They had to train residents, they had to do research, they had to continue their clinical practices, and that's good for that sector, but it isn't always the most
You bring up an
efficient.
interesting thing. Training residents. Do you do any resident training at your place?
Not at the formal level. That's what academic medicine is for. I want to go back and, you know, I think that running a medical practice, it's like any other business, right? And access to capital. You need to run a good business, run it well. And this consolidations that you've seen on the hospital side, also on the physician practice side. WestMed, Mount Kisco Medical Group, Westchester Health, Pro Health, Crystal Run Healthcare,
I mean,
Summit Medical
Tony,
Group,
and that's right.
200, you
Going
know,
back into
200
your
plus
early career,
doctors.
the Summit Medical Group was like the forerunner of this.
Yes, absolutely.
But all this is about consolidations, getting more efficiencies, and when you run a good business, by the way, you do create access to capital, right? Access to capital markets.
Bringing this around to the fact that we are at a real estate show.
No, we're not. We're a business show.
We're a business show, I take that back. But one of the issues that has hampered the development of large groups here is we've not had the access to big parcels of real estate that the western cities have had. And that has clearly fostered the development of group practices.
Unfortunately, what we have in New York City is Manhattan is an island. There's a limited amount of space, and that space is being utilized for residential development or other situations. But I do see that you're going to see with the Hudson Yards and with what's going on in Lower Manhattan, more health care going over there. And, you know, it's happening in certain parts of Long Island. To do this topic in 30 minutes is totally inappropriate. So hopefully, when I start my 14th season in September, I'll have all of you back and we'll talk what's going on and we'll find out about the HEAL program and we'll see how the clash of the two titans. But I'd like to thank Arthur, Ned, Bob, and Tony. See you next week.
Thank you.
Thank you.